wanted to extend an official welcome to my podcast, Soma Says. I'm very excited to be speaking with another physician, MD, who specializes in thyroid, and your background as an ear, nose, and throat specialist. Most of my dealings with ENT doctors when it comes to the thyroid is when the thyroid needs to be taken out.
Exactly. And that's where I started. It's where I started.
Or if
For
maybe
sure.
the thyroid is compressing on something, right?
Yeah, it's either compressing or, okay, there's a tumor. We think it might be cancer. We got to get it out. Yeah.
So you have more of a medical aspect to your practice when it comes to the thyroid. And I'll be honest with you, I'm thrilled that as an ENT doctor, and I understand, and I want you to speak more about this, that you've had your own thyroid issues and how that influenced your practice. I've been practicing for 25 years and up until now, I have not met a single ENT who deals with the medical aspects of the thyroid. Would love to hear more from you about what led to this journey for you.
Absolutely. Yeah, I'm so excited about that. Truthfully, I was the surgical ENT doctor that you're talking about at the same time that I was a thyroid patient, but still didn't know it yet because I started having fatigue and all the other thyroid symptoms probably in high school. And I never had an abnormal TSH. I never had any abnormalities that a full-on mainstream medical doctor would recognize as thyroid, except for the symptoms. And in med school, I was taught if you have low thyroid, then you're overweight. And I never was. But I was also cold and exhausted and had low blood pressure and low body temperature and all the things. So some of the symptoms were there, but I was taught you have to be overweight to have low thyroid. And so it never occurred to me after I had the normal TSH that anything was wrong until I had been out in practice for a while. And it didn't really start there, but that was a big push towards, okay, I need to learn more about this. When I was in residency, I was in a big academic institution. We were taking out serious cancers that had metastasized, and these people need that thyroid gland out. And then I went to private practice, and 90 to 95% of the thyroids I took out, and it would come back, oh, it was benign. And I started getting this, okay, we're hurting these people by taking out their thyroid, because they would come back and the doctor would have said, oh yeah, your TSH is great. You don't need medicine. Or your TSH isn't great. You need to take levothyroxine. And none of them felt better than they did before the surgery. As a matter of fact, almost all of them felt worse. I was like, okay, first do no harm, right? That's medicine. I'm harming these people by doing this surgery. Is there something I can do to prevent them from needing to have the surgery? And so I looked in my textbooks and I looked in the research. It wasn't the internet back then. It was how do you get your PubMed search or whatever. And I found a protocol for let's try to suppress the nodules. And first I was using levothyroxine. That didn't do a whole lot. And then I started using Armour Thyroid, and that did a whole lot better, but still not uniformly great. But less of my patients had to have the surgery right then. And I would talk to them and I'd say, you have this thing called chronic lymphocytic thyroiditis. That's what your pathology shows on your needle biopsy. And it eventually occurred to me, oh, this is an autoimmune disease. We don't treat autoimmune diseases by cutting out the attacked organ. That's silly. And then I had the aha moment when I was at a conference, and it was, I know this is silly, it was an allergy conference, but it was a bunch of people who were trying to think outside the box. The old-time ENT doctors who did allergy or do allergy, I guess most of them have passed away by now, but the old-time ENT doctors who developed allergy were seat of the pants. They didn't even know what IgE was back then. It hadn't been discovered yet. They were experimenting on themselves, experimenting with what they did for the patients and getting them better. And so they had this real, okay, I don't need a double-blind study to know that this is working. I can see it with my eyes. These people have less hives. These people have less asthma. So at this conference were a bunch of people who had that attitude. And I sat in this one lecture, And the guy put up this list of symptoms. And by the time he got to the bottom of the list, my jaw was on the floor because I had almost all of them. And I was like, I have low thyroid. I'd been out in practice for 4 or 5 years by then. And then the bomb that he dropped at the end of that was, you don't have to have abnormal TSH. And it was just like, oh, you mean I don't have to be exhausted all the time? You mean I'm not actually lazy? You mean I don't have to be freezing all the time? I thought I was just a cold-natured human being, but that's what it was. And I went and asked my doc for Armour Thyroid, and I started taking it. Was like, holy cow, this is what normal people feel like? And once I saw that list, I couldn't unsee it. And so I started seeing it in my ENT patients, in my sinus patients. I was like, yeah, I know you're here for sinus, but your hair's really thin and your eyebrows have fallen out. Can I give you some thyroid medicine? Or can we look at your thyroid labs? And the first time one of my really bad sinus patients came back 6 months later, and I said, when are we going to do your surgery? And they were like, oh, I don't need that surgery. That's all fine now. I just need a refill on the thyroid medicine. Boom. Light bulb moment. And then other stuff started happening. It's okay, I've got a patient, she's here for allergies, but she stopped having miscarriages and had a live birth once I put her on thyroid medicine. It was just like, now I'm going to start to cry because those were such emotional moments for me. And I found a mentor who, like me, was an ENT, like me, had thyroid problems unrecognized for years, but he was about 20 years ahead of me. So he had already done a lot of experimentation, and he had figured out some things about thyroid labs that I didn't figure these out. He figured these out. And there's another fellow, his name is McDaniel. There's another fellow in New York named Levy. So there are several ENT doctors who have this, okay, as long as I'm not harming my patients by giving them a trial of something that's not in the mainstream, they feel terrible. They're willing to try. We're signing a consent that says, I understand this isn't mainstream. I'm going to try it. And the more I learned about that, the more I learned, okay, thyroid does not exist in its little capsule by itself. It is connected to all of our other hormones through the adrenal glands, through sex hormones, through binding globulins, that kind of thing. So, my patients would come back and go, hey, doc, can't you do my menopause hormones? And I'm like, no, I'm an ENT. I can't do that. But as I got to the point where I was ready to leave the practice that I was in, menopause, and my eyes started going bad. And my mom is getting older, and I need to have time to take her to doctor's appointments. And I was looking for something that I could do not 5 days a week. And when my partners were not willing to go there, I was like, okay, I guess I'm going to go and do my own thing. And I was ready to stop doing surgeries, at least the really hard ones. I was ready to stop doing them anyway. And so it made sense. Okay, I'm going to go and I'm going to get the training. I'm going to learn to do the menopausal thing. I got my menopause certified practitioner last year, which I'm super excited about. I kept learning from Dr. Allen, who has actually a hormone course that I help him teach now, which is great fun. And the more I learn, the more I know, oh my gosh, I have a lot to learn. And the more I know, the more I can help people. And it's just been really exciting. It's been really exciting.
I often say on my podcasts and life too, that doctors are often trying to heal themselves. And that could be based on whatever past that we've had. And we try to heal others. And in doing that, we heal ourselves. And so it sounds very much that's what you were doing. And I also wonder, those of us who've had these kind of things, how much of it inspires us to become doctors. You don't really think about it. I know someone who ended up having a brain tumor, which was discovered later in life, and he's fine. But he was a neurosurgeon, and he read
he read his own scans.
Read his own scan, and he figured it out. So you often wonder how much of that influences our decisions that we make in real time.
Yes. Since I've been doing my own podcast, I always ask my guests, okay, how did you get into this? Just like you asked me. And almost always it's a family member who had an illness, or they themselves had an illness, and the conventional way of doing things was not enough to help them get better. And so they started looking outside the mainstream and came across things that are still science, but maybe don't have 1,000-person double-blind placebo-controlled drug trial because most of what we teach is not drugs. And there's not big trials that explain why these things work. And so you have to go back and you have to look at and I'll use mold, for example, because mold illness is something that's very controversial in medicine these days. But you have to go back to those old ENT doctors who were treating mold allergy and sensitivity and who were treating food allergy and sensitivity. And whether or not it has anything to do with IgE, turns out it has a lot to do with whether you have insulin resistance or not. And removing this food or that food, it may not be actually because of an allergy, but it might be because you were insulin resistant. And getting rid of that made you feel better. So yeah, we don't always have to know 20 years of research on something before we say, okay, is this going to hurt my patient? Can we try this? Let's see what happens. And then if it works on them, then maybe you can do a study of 10 and see, okay, 90% of them got better. Wow, this is great. Let's keep going. That's how medical research used to work.
Doesn't quite work that way anymore.
Not so much anymore. Yeah, it seems like it's really been captured by the big academic institutions and the big pharma. Yeah.
One of the questions that came into my mind as you were speaking is that the research has also been not as vigorous when it comes to women's health. And as from what I know, thyroid issues present more frequently in women than
about
in men.
90%. Yeah, about 90%. So true.
Why women? Why us?
Why women? Why us? I think it's because our hormones cycle up and down, and that creates stress, and stress pushes people towards Hashimoto's disease, which is an autoimmune disease. And that's actually the most common reason for people to end up with hypothyroidism. But to your point, I really think that medicine has been was, thank God it's not anymore, an all male profession. It was very patriarchal and it was very dismissive of women's complaints. Initially, it was like, oh, you have menopause. There wasn't anything that could be done about it. So let's just minimize it and dismiss it. Now that we actually know, okay, what is menopause? It's the fluctuation and then the loss of the ovarian function. And we can actually do something about it. But the dismissive attitude is still there. And it has become institutionalized in its days. But Hashimoto's disease, it's funny when you look at it, 50% of it occurs in perimenopausal women. Why? Because their hormones are going crazy. When's the other most common time? Right after a pregnancy or during a pregnancy. So it really does have something to do with the other parts of the endocrine system. And that is not entirely clear why that happens.
Similar to, I don't even know if it's similar because when I went to medical school, I don't even recall learning really anything about menopause and the treatment especially. I just don't remember. And this was a few years before the Women's Health Initiative came out. So even then, I don't think that I had much exposure to it. And then everything changed. And I'll tell you my story in terms of practicing. It was the standard, okay, the TSH is normal, your T4 is normal, you don't have hypothyroidism. But then you have patients who, as you were mentioning, have every single symptom of an underactive thyroid. And a lot of patients feel very frustrated because they, number one, feel exhausted and they're not functioning properly and they're not getting heard. And when they approach their allopathic physician, they're being told your labs are normal, you don't have an underactive thyroid. Yeah. So they often feel they have no place to go. And I have patients who feel that way. And to be honest, because I haven't had that exposure, I've been learning, and I feel like I've been changing the way I practice when it comes to the thyroid. I've been relying on my functional medicine physician colleagues to help me so that I understand how to deal with it. But it was not something that I was exposed to in medical school or in residency. Why is that? Why is it just lab-based, and why aren't the symptoms accounted for?
That's a great question. And I think there is a tendency for humans to brush under the rug anything that they don't understand. And truthfully, we have been fed from, here we go, it's pharma again. We have been fed a line by the manufacturers of Synthroid that A, it's great to give it once a day, and B, that it's the only thing you need. And the other stuff can go spit. And we could spend a lot of time talking about the history of Synthroid and the history of thyroid treatment. But before Synthroid existed, the treatment was a combination product that had T4 plus T3 in it, in coming from cows or coming from pigs. It was a natural product. And that product still exists, but the pharma companies have done a really good job of delegitimizing it because it varies and because it's got possibly contaminants in it because it's from an animal. So it's not. And I like to see that coming the other way. Now, people are like really hyper focused on things being natural, but just because something is natural or synthetic doesn't necessarily make it better or worse. What makes it better or worse, is it the right drug for you, or is it the right hormone combination for you? But yeah, Synthroid was invented before the TSH test was even invented. And then when they're like, oh, we can predict how much Synthroid you need by this TSH test, then it was like, okay, now it's institutionalized. The fact that we have a test for free T3 now, and the fact that we have a test for reverse T3, and that reverse T3 is actually important, is something that gets really just completely ignored in the mainstream medicine powers that be that decide what the guidelines are going to be. And it's funny because I talk to endocrinologists and they're like, oh, yes, we see that there are some people who don't respond to levothyroxine, but we don't know. And some people do better on a combination and some people do better with T4, but we don't have guidelines that tell us what to do. Therefore, we're not going to do it at all. I'm like, and I'm telling you, here's a study that you could do that would help us get some new guidelines. And it's almost like they don't want to hear. They're comfortable with their guidelines and they're comfortable saying to their patient, I don't know what to do for you, which drives me crazy because it does, like you were saying, it drives the patients into the hands of, and there are physicians who are functional medicine, but there are also a lot of people who claim to be functional medicine physicians, and I'm using air quotes here, who are chiropractors and nutritionists. And there's even one that's a fitness model, for Christ's sake, who's out there telling people crazy things to do to fix their thyroid. And it's like, there's no science behind it. It drives me crazy with the stuff that they tell the lay public. And now that there's TikTok and all this stuff, people are getting all these ideas that, while they're not totally ridiculous and maybe they're more effective than what their allopathic physician is doing, there's got to be a happy medium. And I feel like I'm the happy medium. I'm just not known. So that's, sorry, I'll come down off that soapbox now.
I think by doing podcasts, by appearing on different channels, you are becoming known. So I wouldn't say that you are not known. So I can imagine, and this has been my experience, because if you're not necessarily using labs to guide how you treat your patient, you're going by your clinical instinct, you're going by how they're responding to treatment, medications.
Yeah.
That becomes a little difficult because you may need to see that patient several times.
But I can go by the labs. That's what's so great about and like I said, I didn't discover it, what Alan has discovered, because he has taken this concept that reverse T3 is a competitive inhibitor of T3 and that your body uses it to slow down. Our bodies are much more primitive than our society. And we are from a society where starvation was common and severe illness and injury are common, and medical care was not common. And so your body has all these mechanisms to slow down energy burn. And it has no mechanisms to handle unlimited free access to processed calories all day long. It has no mechanisms to handle that. But what it does have is a mechanism to handle stress. And unfortunately, it's like a carpenter who only has a hammer. Cortisol is like the hammer, and your body uses cortisol to handle stress. And unfortunately, what that does is it raises your insulin resistance. It raises your blood sugar. It makes you want to eat more starchy carbs. It does all these things. And it also pushes down on your TSH, which lowers your free T3 and your free T4, but it lowers the drive to make more thyroid hormone, lowers the drive to convert T4 to T3 to activate your metabolism. It increases your drive, unfortunately, to end up with autoimmune thyroid diseases, which is an unfortunate side effect of all of that. But it's like when you look at how much T3 you have in your body versus how much reverse T3 you have in your body, and you compare those, you can tell, okay, is my body activating thyroid hormone or is it deactivating thyroid hormone? And so it comes down to you take you take a total T3 measurement, you take a reverse T3 measurement, you divide one by the other and you get a ratio. And when it comes out of your thyroid gland, it comes out at about 10-1 into your bloodstream. And so if you measured total T4, total T3, you would see there's about a 10-1 comparison if you measured to like. And so if you keep going with that progression and you go total T3, reverse T3, as it comes out of the thyroid, that 10-1 progression again. And so if a person in their body has a total T3 divided by reverse T3, that's 8 or 7 or 6 or 5 or 2.5, which I've seen, you know they are inactivating thyroid hormone. And then you look at their situation and you go, okay, are you critically ill in the ICU? Are you starving to death? And some people are because they're dieting because they want to get thinner. And so they're starving themselves to death. So what happens? Reverse T3 goes up. Are they lacking in sleep in a significant way? And so many of us are these days. So there are all these situations that put you into a relative deficit of T3 where you need it to be 10-1 or higher than 10-1. And so there is no published reference range for T3 to RT3 ratio, but I say the reference range is 10-14. If you're a teenager, maybe 16, 17. But so I can use that lab and it's not expensive for me to order. It costs me about $20 every time I order it when I pay for it directly to the mainstream lab. So I charge my patient $22 for that lab. And I can use that to follow to see if I have their thyroid hormone replacement correct or not. So that's how that works. So I'm not just guessing, which is great.
No, definitely not guessing, obviously. This has been eye-opening, and I do hope, in addition to my usual listeners, that I hopefully have more doctors who are listening in. And I would love for them to go to the course that you were talking about. I know I'm going to check it out.
Okay.
And so I will definitely include that in my show notes. And if my listeners do want to learn about you, obviously take the course that you mentioned, find you on social media, listen to your podcast, where do they go?
Okay. So the podcast is called Beyond the Thyroid. And it is on Apple Podcasts, Spotify, etc. So it's pretty easy to find. My website is danagibbsmd.com, pretty straightforward. And there are links on there to the physician course that's called the New Endocrinology. And we're going to actually start that up again in April, probably second week in April. It is a 12-week very intensive live taught. It's not a recorded thing. It's a live taught with Q&A every week on Sunday evenings with recordings so that you can come back. Once that's done, then we have a discussion group and we meet almost every Sunday off no recordings, off camera. So anybody can bring a case and go, okay, have this patient. Here's what their lab showed. What do I do next? And we all pitch in and help manage each other's dilemmas, basically, which is great. So great.
That sounds awesome. And as I said, I will definitely check it out. As I was thinking, because my schedule is so crazy as it is, but this is stuff that, again, it's hard to find people who are willing to teach you. And my ego isn't so big that I can say that I don't know everything. And I think that's what makes a good doctor, a person who's willing to learn and admit that they don't know everything, but they have this desire to help as many patients as possible. And that's definitely you, Dr. Gibbs. So thank you so much for coming on my podcast. Before we end, wanted to know if there was something that you absolutely wanted to say that wasn't included in our discussion.
Oh my gosh. It's funny because you just touched on it, which is that especially for physicians and especially for other people who are around the fringes of medicine or who practice functional medicine, is beware when you think you know everything that there is to know about a subject, because that's arrogance. And there is always something more that you can learn. So that was it.
I think there's so much more we can talk about. Honestly, that's my sense of our discussion today. But yeah, I would love to have you on my podcast again. If there are other topics that you think would fit in, I can think of like at least 5 different things right now.
You tell me and I'll talk about it.
Thanks so much for your time today.